It's a pleasure to be here. I had a chance to come to Haltland lecture soon after I moved to Dallas. It's a pleasure to be back. In infectious disease, we always hope that Tom Zellers and his team are going to invite us back because it's so helpful to be able to talk with people in the community and to hear what you're noticing. And actually, I think that's one of the overriding themes of my preparation of this talk, in that this room probably has some of the most sophisticated pediatricians in the country after the last year or two in terms of presentation of encephalitis. And I thought that we'd talk some about what we think we've learned in the last year, and if there's time at the end, we can try to postulate what the future might hold. So what I thought I'd start with, I guess the only disclaimer that I should offer, I don't have conflicts of interest in terms of drugs or diseases, but I am the Pediatric Residency Program Director. The second message I'd like to get out in the talk today is that we have a table out in front that Kat from our office is helping to staff. And there are a few things that I'd like you to just be aware of. One is there are cards that we've laminated that on one side have numbers of an effort we've been working closely with Children's on, which is when you have a patient at Children's, how can you find them and how can you talk to the team taking care of them? And how can we get information to you? And then on the other side, just a general phone number for our office. It's a separate discussion. I don't want to eat up too much time today, but I have a specific goal to have more pediatric education happen in collaboration with the community. And I'm not going to roll that out recklessly, but I'm going to need to work with partners so that I can learn what would make it worth it to people to have pediatric residents affiliated with practices. That's a talk for another day, but if you come and visit the table, we have information. We also have information that we printed out on folks in my program who are interested in primary care jobs in the area with some background information about them. Okay, so the talk for today, in terms of encephalitis, I want to start off with a disclaimer that there's not going to be enough time in this block to talk about all the other things that can present with encephalitis, like drug intoxications or meningitis or parameningeal infections. So this is going to be a fairly coned down talk for straight up encephalitis. And when I get a call about a child who has encephalitis and I'm trying to think, well, what could this be? As a microbiology nerd guy, I tend to filter it through, well, what organisms might I think about? On the handouts, you've got a blank spot like this. You might just take a couple of seconds to think about what you might put on this list. And it's an interesting discussion how people get to those. You know, I sort of think about the scary stuff first, and then the things that I'd be embarrassed to miss, and then the stuff that I've got a treatment for, and everybody processes this their own way, but you know, I think thinking about different life forms is a reasonable approach. And things that I would put on my list is some of the considerations. This isn't an exhaustive list, but you know, certainly herpes, because with our PCR capability and our acyclovir options, we can make a difference with this, and it's pretty common. Arboviruses, quite common, seasonal, usually not devastating unless you're a young infant. Arboviruses, which I've highlighted because I'd like to go a little deeper on that today. Influenza, especially A, which seems to come through with certain types that are more encephalopathic than others. When I was in St. Louis, before I came here, we had an outbreak of influenza A, and some of those children still can't walk or talk. We called the CDC, they did an outbreak investigation, and it turned out that one year that was hitting all over the country. In Japan, they've talked about this much more than here, but now and then an influenza strain will come through and really cause a horrible wake of damage of encephalitis. And then rabies, which, you know, from the experience in Milwaukee, is now a potentially treatable disease. And as more and more people, particularly your teens and adventurous young adults, are traveling to exotic places, now and then you'll have somebody who comes back from a trekking trip and they've got rabies, and it's the care that they get after they get home that helps figure that out. Bacterial, I think things that cause encephalitis as opposed to meningitis or parameningeal infections. Mycoplasma, I think, is very important to think about, and I'd argue that this year we've seen a lot of that. We'll talk a little more about that. Cat scratch disease is one of the most bizarre encephalitises that I ever get to see, because oftentimes it's a very dense encephalopathy. It lands a child in the unit, and then almost without fail at day 4 or 5 they wake up and say, where's my kitty? It's a really amazing process, but it's worth thinking about. And I'll talk a little bit about a rare class of amoebic infections. We've had both Naegleria and Balamuthia infections in the last year, and I think it's worth at least getting them out there. So let's talk, and we'll split it pretty much into thirds for the talk. Let's go pretty deep on arboviruses today, and this is a daunting task because you've seen and read and thought a lot about West Nile already. I don't know what else I can offer to your expertise, but there's a paper that I like in Nature Review Microbiology written by some of the expert arbovirologists in the country where they try to talk about mechanism. And to be honest, this is one of those first pass papers where you read it and you kind of wonder, well, what part of the immune system isn't involved? It's pretty broad. But this is a figure that I like a lot because I think it has some actionable information in terms of thinking about natural history and why it may look the way it does. And so this figure that from that paper starts with the arthropod-borne viruses, in this case focusing on West Nile, but also things like St. Louis and Japanese encephalitis. There's this early phase where it looks like the virus gets into the superficial layers of the skin, and it seems as if this part of the immune system, the dendritic cells, seem to attack but also consume and perhaps propagate the West Nile virus. And that may be one of the ways that the West Nile virus moves around our body. At the next stage, and this was something I hadn't really thought about so much until I read this article, those dendritic cells tend to go to lymph nodes, and actually many people who have West Nile encephalitis will have a lymphadenopathy as a middle stage of their disease before they present with any of the neurologic findings. And so as you're trying to make sense in a busy summertime, does this fit or does it not, lymphadenitis is not 100%, but oftentimes that can be part of the disease, and we believe that it's part of the pathophysiology. It seems like from the lymph nodes there is a subsequent dissemination that goes to certain organs that are particularly receptive to West Nile proliferation, including the spleen, but also the liver and the kidneys. And then where it gets particularly interesting and scary is who gets neurologic involvement. And this is the big question because, you know, most people have a West Nile infection. They sort of feel like they had the influenza, and that's the end of it. But then there are some people who it can be neurodevastating. And there's been a lot of work trying to figure out how things like the dendritic cells cross the blood-brain barrier. It looks like aspects of the innate immune system, like tumor necrosis factor, loosen up the barrier along the endothelial cells and let the virus get in. This is the so-called Trojan horse model, where the dendritic cells may carry the virus into the brain. People think this is one of the ways HIV gets into the brain as well. And then the big question is, who's going to have this? Who's going to have infected and damaged neurons? There are some early hints that there may be some genetic variations, that some people are more vulnerable than others. They haven't held up to the point where it's at all predictive. We're still really catching up on this story. The other thing that's been really interesting for me this year is I was just finished my residency when the first West Nile wave came out of places like the Bronx Zoo on the East Coast and worked their way west. I remember doing 20 lumbar taps as a young fellow. We had so much encephalitis. And I have to say, after that experience, I thought that for the most part, kids usually didn't get too sick with West Nile, and it was usually something that they shook off pretty well. And this year, I don't know if it's just that we've had so much that the rare things are now being seen, or if maybe the strain has changed. These are still active debates. But there are some really frightening neurologic manifestations that kids can get. The first outbreak on the East Coast, the CDC would do these studies and find that if you were an older gentleman who smoked on your porch in Queens, New York as the sun set, you would get the disease. It was sort of a profile. There was this great paper where they even mapped it to certain storm sewers in Queens and the radius that mosquitoes could fly. I mean, this year it's really been humbling for me because kids get this and they can get it really badly. So I wanted to show you a video clip of a patient who I got to take care of this year. I think it sort of speaks for itself. I'll just play it and then we can talk a little bit after it. It runs about 2 minutes. So I think that the lesson from this for me is we're still figuring out what the complete range of clinical manifestations is, and I think a group like this in aggregate is going to see things that we just hadn't appreciated before. So going forward, I think that one thing that's really important for our community is to move out data sets that let you have really up-to-the-minute information on the epidemiology of what's going on. And it's about tax time. I was explaining taxes to my kids, and one of the things that I actually am happy to pay taxes for is this thing called ArboNET. And it was built by the Centers of Disease Control with the U.S. Geologic Survey, and there are these really sophisticated maps that you can get to on the internet that I think are very helpful to try to figure out what's going on in your community. It's got maps county by county that also reflect the virology and epidemiology of arboviruses. These are the different abbreviations: West Nile, St. Louis, Eastern and Western Equine, La Crosse, Powassan, dengue. And then I think this is an important reminder that the life cycle of West Nile is this really amazing dance, because the virus moves between birds and humans via mosquitoes, and the birds serve as amplifying hosts. And this map is really sophisticated because it lets you scroll into each of these viruses and each of the different components of their life cycle. And then the other thing that I think is important to remember is that this also tracks veterinary cases. When the first West Nile viruses came out, it was veterinarians who figured it out. It wasn't physicians. And knowing that these all exist, I think, is helpful. The other thing is, as I get more familiar with the area, all those horse farms around Denton make me nervous, right? Because if there's one of these that terrifies me, it's Eastern Equine. And those horse farms around Denton would be a perfect place. And so if, as a group, you started to have people who had really dense encephalopathies, thinking about exposure to mosquitoes that have been near horses is important. So not to belabor the point, but just to try to get you intrigued by this map, it's really nicely done. You can scroll down by state. It shows you cases by county. It gives you a nice epidemiologic curve versus time. I think it makes people really sophisticated in terms of their epidemiology. We've also partnered with the Dallas County Health Department. Wendy Chung trains all of my residents now as part of a community pediatrics training module where they learn pretty nuanced public health insights. And then now and then there are things that are kind of funny on this map, at least to me. So this is mapping mosquitoes that are positive, and I'm from this part of the country, and I think the mosquitoes probably cross the border from Indiana to Ohio. And so sometimes if you can see a state boundary based on a map like this, it probably means this Department of Public Health is a little more vigorous than this Department of Public Health. So it's not perfect, but it's a nice map. And then I'll just put one more plug in for horses make me nervous with arboviruses, because Eastern Equine could take off in this area, and it would make West Nile look like a cakewalk. So I put in 3 CME questions. I think one of the nice parts of ArboNET is that it allows you to track the arthropod-borne viruses species by species and the key contributors, including these. There are these other aspects that are certainly important, like how much it rains and who's spraying. That's not on this map. And then another map that I think is nice for you to know about is ProMed. So another case of encephalitis that I had this year was a child who was from Thailand. And I said to the floor team, "What do you mean Thailand?" Well, he was really a Burmese refugee who'd passed through Thailand. And we actually take care of a lot of folks from Burma now in the Metroplex, because this seems to be a designated founder relocation center. And so we've had cases of Japanese encephalitis here too. And DFW, just a few hundred meters away from here, has about 2 million visitors from overseas every year. And so thinking about viruses from other parts of the country are important. Japanese encephalitis, if you go on ProMed, again free, you can get maps that show where it's happening, how recent it is, and it's a nice additional resource if you're thinking about international health. I used to work for WHO. Actually, this is much better mapping than anything you'll find at WHO, because it's almost real time. Okay, so I'd like to segue here. I think we're still on track. to another class of encephalitis. So this organism's been associated with encephalitis, which can occur in community clusters of pediatric cases that may also involve pneumonia, Stevens-Johnson syndrome, and a notable lack of routine public health reporting. So everything I just told you about these arboviruses does not apply in terms of public health tracking for this organism. Any ideas? You've probably seen a lot of this year as well, Mycoplasma pneumoniae. And we've had some very dense encephalopathy with kids who had compelling evidence for Mycoplasma. So I thought I'd talk a little bit about it. This is a paper I try to use to teach my residents. It's a wonderful CDC investigation a few years back. Rhode Island shut down all the schools in the state in the midst of this epidemic because they had clusters of encephalitis. And very thoughtful epidemiologic work found that within a given school, so these are cases within a single school around Providence, Rhode Island, they had these kids accumulating where these were visits for coughs. These black bars were documented pneumonias. Then there was one child in this school, but there were another 6 or 7 in the state who had Mycoplasma-associated neurologic disease. And about the same time, somebody had Mycoplasma-associated Stevens-Johnson's-like disease. And this is what we saw last year. We noticed it first at Legacy, where we had these kids who had rip-roaring Stevens-Johnson's. Some of them would have encephalitis, and it was Mycoplasma. And nobody keeps track of Mycoplasma. It's not a reportable disease. And so a group like this is the kind of frontline group that over time I would love to have your insights feeding into the infectious disease division, because I've had actually people sitting in about the 5th row call me and say, oh, I've been seeing something in my office, what do you think about that? And I didn't know it was going on except for what I heard from colleagues in the community. But I think Mycoplasma is really important to know about. The other thing that this paper points out is a lot of this was school-based. And so those of you who work in partnership with schools, with school nurses, you may figure this out way before we figure it out downtown, because by the time it gets to us, it's often been a few cases. I'm still learning about Mycoplasma, and I think a lot of what we learned in medical school is still true, but it's still debated, and that is, excuse me, when you get a Mycoplasma-associated encephalopathy or a transverse myelitis, how much is the immune system that's just sort of revved up and you've got a para-infectious process, and how much is the infection itself? And we still don't know the answer to that, and I have a feeling it's not one or the other. But this is from a really nice paper that looked at children who had died and adults who died of Mycoplasma. And so these are autopsy specimens from brains. And I think that what this points out is there's a lot of perivascular infiltration around the blood vessels. And that's consistent with a peri-infectious process. And then it gets interesting, because if then you do a stain with antibodies against Mycoplasma pneumoniae, and those are the dark colors here, it looks like at least some of these cells have some antigens from the Mycoplasma. Now, does that mean that they ate it up and they're just trafficking it around? Does that mean there's an active infection? We still don't know. This paper has really forced me to rethink my traditional thinking, which is, you know, it probably doesn't even matter if you give them an antibiotic because it's probably all peri-infectious. These are now electron micrographs. I'm going to go to the place where I've marked them up a little bit. So Mycoplasma is a really tiny intracellular bacteria. And it looks in ultramicrographs kind of like fried eggs, so these red circles around things that look like there really are Mycoplasma. To give you an idea of scale, these are ribosomes next to that. So it's really, really tiny. And this is inside a child's brain in a neuron cell. Here's the nucleus, and here are these things that they really look like they are living, invading Mycoplasma. And so in terms of actionable information, I think that I need to revisit my thoughts of, you know, it's just an off-target inflammation response, and maybe thinking about giving antibiotics that will cover Mycoplasma are reasonable. People still don't know the exact answer to this, but I think this was a really interesting finding. Now, this paper also goes deep and talks about it may be that if you present with encephalitis at a certain stage in your illness, it's more likely to be inflammation as opposed to direct invasion. That's still being debated, but I think it raises some really interesting questions about what's really going on. One thing that I still like to do as sort of a parlor trick is cold agglutinins. Who can resist cold agglutinins? It's great, it's at the bedside. Now, one of the things that's really changed our practice and helped us, I think, to figure out when it's Mycoplasma at all and what Mycoplasma might be doing is cold agglutinins are kind of passé now. Their sensitivity and their specificity just isn't good enough. Fortunately, now there are PCRs to Mycoplasma that you can get from a nasal pharynx that is a really good test. And that helped us so much this year because we were able to say, you got Stevens-Johnson's, you sound like you might have Mycoplasma, and then we get the PCR, and we've got it, and we can understand what's going on. It's a very helpful test. Okay, then this is pretty obscure, but I think important for people to at least think about, because we've had kids with both of these this year. So Naegleria and Balamuthia are associated with encephalitis that can be contracted from, in the case of Naegleria, freshwater swimming, and in Balamuthia, traditionally soil exposures, particularly in warm climates. And the reason for this is if you live far enough north, the temperature of the water drops down below the sustainable temperature of these organisms. But if you live in a place like here, when you dive into the Red River in the summer, you can have the Naegleria driven up through your cribriform plate and infect your brain. And these are terrifying encephalitis infections, and these are amoebas. And we had one patient who came, who was a school-aged boy, came to the ER with mental status changes and fever following diving into fresh water during a hot summer weekend. And one of our hospitalists, this is actually a recent graduate of my program who's wonderful, Christina Seeley, who previously trained as a medical lab professional, heard this story and called the lab and said, I've gotten CSF. I wonder if we should think about freshwater amoeba, and I think we might find it on a direct stain, maybe a right stain. And the lab said, yeah, we'll do it. And so this is a picture from his CSF. These are white cells, lymphocytes. These are neutrophils. Here's a red cell for reference. This thing here with the little bleb, that's the amoeba. These are little organelles inside there. And I don't think this is just an artifact. I think actually this is an amoeba that is phagocytizing a red blood cell. And this child had Naegleria. These are other pictures of it. And again, I think actionable information is only by thinking about this can people get the ball rolling soon enough for these kids to have a chance. These can be treated with things like antifungals, sometimes macrolides. The survivorship is still, the survival rates are still disappointingly low, but if you start early, you stand a chance. And also it has some potential public health implications. This is a blow up of the picture I showed before. We were getting serial pictures from his CSF, and we thought that we were causing the amoebae to die. He ended up passing away before we could get on top of it. Balamuthia moves more slowly. The classic story is like a dirt bike rider. It looks like it may be in the soil and may get driven into the brain. But if you don't think about it, it's just, you're not going to realize what's going on. So shifting gears to what we've got out in the hallway, this is one side of the card where, like I said, we've really worked closely with children to ask questions about how can we let people's long-term pediatrician know what's going on when you send kids to the hospital. We'd like feedback on how that's going. There are primarily former PICU nurses who are running the lists of the census every day at Children's, looking to see when somebody transfers, learning practice by practice, who likes to be called, who likes to have a message left, what kind of message it is. I've been teaching my senior residents to engage with this, to teach them to be good physicians and good communicators. And then Kat Robinson's out in the hallway. This is our phone number. Like I mentioned, I'm very interested in, over time, thinking about how to build resident and medical student education that involves the community more, asking questions like, what would make it worth it to you? You know, would a Part 4 MOC project with a resident make it worth it? You know, would having a person in-house who will check on your kids when they get admitted be worth it? I realize how busy things are, and you know, I want to do this in a way that's thoughtful, but I'd like to put it out there that I'm actively looking for partners in this. And then these are my current residents. We have 100, including wonderful chief residents. People keep signing up to be chief, even though it's a really hard job. And last year we had 13 of our 32 second years say they wanted to be chief, which is amazingly selfless. And these are folks who are in their second or third year who are interested in primary care in this community. We've got individual sheets that describe some of their background and contact information. Any of you who are interested in learning more about them, I'd invite you to stop by our table.